Presenting a Plan, Do, Study, Act cycle focused on improving screening for health inequities. We will show how structured quality improvement process can support more consistent identification of patients at risk due to social determinants of health. The project was completed by Tricia Marie Alaris, Betty Robbins, and Larissa Zidon. In the presentation, we will walk through why health inequity screenings matter, how the PDSA framework guides improvement, and the changes we propose to strengthen screening practices in the clinical setting. Our group identified the lack of standardized health inequity screening process during patient intake as a major issue. Without consistent screening, key social factors like housing, food access, and transportation are often missed, contributing to disparities in care. Evidence shows that using structured SDOH screening tools helps clinicians identify unmet needs, improve care coordination, and reduce readmissions. The Institute for Healthcare Improvement also recognizes this screening as essential for advancing health equity. Despite these benefits, many facilities still lack consistent workflows and staff training, leading to uneven implementation. This slide outlines our SMART AIM statement, which guides the direction of our improvement project. Our goal is that within 1 year, the organization will implement a standardized health inequity screening tool, such as an SDOH questionnaire, for at least 80% of patients during intake. This helps ensure we are consistently identifying and addressing unmet social needs that impact patient health. The aim is specific because it focuses on one defined change, introducing a standardized screening tool. It's measurable with a clear target, reaching an 80% screening rate. It's achievable through planned strategies like staff education, workflow integration, and pilot testing. It's relevant because it directly supports our mission to advance health equity and improve patient outcomes. And it's time-bound, giving us a 1 year to accomplish this goal. By using the SMART framework, our project remains focused, realistic, and easy to track throughout the implementation process. Allow me to summarize how we will use the PDSA cycle to guide our quality improvement process. In the plan phase, our team will design a standardized health inequity screening process and prepare to pilot it with new patients. This includes selecting the tool, training staff, and outlining workflows. During the do phase, we will launch the pilot on a small scale, such as in one clinic or unit, to test the process in a controlled, manageable setting. In the study phase, we will evaluate the data collected during the pilot. We will look at screening rates, staff feedback, and whether the tool helped identify unmet social needs or improve care coordination. Finally, in the ACT phase, we will make an informed decision about next steps, whether to adopt the process as is, modify it, or reconsider the approach. If the results are strong, we will move forward with standardizing and expanding the screening process across the organization. Overall, the PDSA framework ensures we continually assess, refine, and strengthen our improvement initiative before full-scale implementation.
During the plan phase, the team prepares for a consistent, effective, and culturally sensitive health inequity screening process. This begins with identifying key stakeholders, including nurses, intake staff, and social workers who will carry out the screening. The team then selects or adapts a validated screening tool, such as the AHRQ Social Determinants of Health tool or PAPER, also known as Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences, to ensure reliable and meaningful data collection. The AHRQ tool helps providers systemically document social needs like housing instability, food insecurity, and transportation barriers to guide care planning and connect patients with resources. PAPER, on the other hand, supports its standardized collection and use of social determinants data, enabling tailored interventions and improved population health outcomes. Next, the team develops a workflow that clarifies when and how screenings occur during patient intake, aligning with current processes to limit disruptions. Staff training is emphasized, focusing on proper tool use and culturally sensitive communication that respects diverse backgrounds. Finally, the team creates patient-facing educational materials explaining the purpose of the screening to promote understanding, comfort, and engagement. Plan phase, timeline, and initial goal. In the plan phase, we not only define what we want to achieve, but we also create a timeline to guide our work and set measurable goals. Our planning timeline spans approximately 9 months, with the ultimate goal of having the screening process ready for pilot testing. By the end of the phase, we aim to screen at least 80% of new patients at the pilot site to identify unmet social needs and inform patient care. For months 1 to 3, we focus on the foundational steps. During this time, we select a validated screening tool, such as the AHRQ or SDOH tool, or Prepare, and design a workflow that integrates the screening seamlessly into patient intake. This includes identifying who will conduct the screenings, when they will occur, and how the information will be documented and used. For months 4 to 6, we center on preparing staff and the pilot site. Staff receive training on proper tool use, documentation procedures, and culturally sensitive communication strategies. We also set up the pilot site to ensure it is ready for full implementation, addressing any logistical or workflow challenges identified during this phase. Months 7 to 9, we are dedicated to launching the pilot screening. Staff begin conducting screenings for all new patients at the site, while we collect ongoing feedback from both staff and patients to refine the process. Our initial goal is to screen 80% of new patients at the pilot site. This goal allows us to demonstrate measurable improvement and provides a clear benchmark for success. We will track progress using 2 main metrics: baseline data, which is a current screening rate for social determinants of health, and the post-implementation data, which is the percentage of patients screened using the new SDOH tool, which will allow us to evaluate the effectiveness of our workflow and training. This timeline and these goals provide a structured approach to ensure that our screening process is both effective and sustainable, setting the stage for successful implementation and measurable impact. On this slide, we're presenting our fishbone diagram, which helps us identify the root causes contributing to the lack of standardized health inequities screening process in our organization. We organized potential causes into 6 main categories, and that is people, process, environment, technology, leadership, and measurement. Starting with people, one of the biggest factors is limited staff awareness and training related to social determinants of health. Many staff members are not familiar with how inequities impact patient outcomes or how to address them during clinical encounters. Competing priorities and time pressures during patient intake also play a role. Under process, our clinic currently lacks a formal workflow or policy for health inequity screening. Staff may not know when or how to complete screening tools and referral steps for patients with identified needs, and it's often unclear or inconsistent. In the environment category, time constraints are a major barrier. Intake appointments are often brief, leaving little opportunity to ask social or sensitive questions. In addition, a lack of private space can make patients feel uncomfortable discussing personal or socioeconomic issues. From a technology perspective, the Electronic Health Record, or EHR, does not yet have an integrated section for documenting SDOH screening results. And without built-in prompts or fields, it's easy for staff to skip this step during intake. Looking at leadership, there's no organizational mandate or performance metric tied to health inequity screening. Without leadership-driven accountability, the process tends to lose momentum over time. Finally, under measurement, there's a limited tracking of outcomes related to health inequities. Because data are not consistently collected or analyzed, it's hard to demonstrate the impact of screening or justify a resource allocation. By mapping out these causes, we can see that addressing this issue requires a multifaceted approach, including education, workflow design, AHR integration, and leadership engagement. This diagram helped us pinpoint where to focus our PDSA cycle for the greatest impact. In the due phase, our team will begin implementing the standardized health inequity screening process on a small scale to test its effectiveness. We will start by launching the screening process at one pilot site, allowing us to manage the change closely and observe the workflow in real time. Beginning small helps us identify any barriers before expanding to other departments. During this pilot, all new patients will complete the screening during intake. This ensures the social determinants of health are assessed consistently from the first point of contact, helping us identify unmet needs early. To support successful adoption, we will provide ongoing staff support and coaching throughout the pilot period. This includes brief training refreshers, addressing staff questions, and ensuring that everyone feels confident using the new tool. We will also collect feedback from both staff about how the process fits into existing workflows and how user-friendly the screening tool feels. Lastly, we will track screening completion rates and referral outcomes to see how often the screening is being completed and how many patients are being connected with needed resources. This data will guide the next steps in our study phase.
Hello, my name is Larissa Zidon, and I'll be presenting the remainder of the slides. During the pilot phase, we'll be collecting data over a 6 to 8 week period, evaluating how well the new screening process is working, focusing on both process measures and outcome measures. For the process measures, we'll track the percentage of new patients who are screened and staff compliance with the workflow, assessing whether the process is being implemented as planned and if additional training is needed. For outcomes, we will monitor how many social needs are identified and how many referrals are made. This information shows whether the screening is actually helped connect patients to support. We'll also gather feedback from staff and patients through surveys. Their input will be essential in understanding the usability of the tool or any barriers or opportunities to make improvements before the broader rollout. By tracking these indicators throughout the pilot, we will identify trends early, make adjustments, and ensure the process is effective. In the study phase, all data collected during the pilot will be reviewed to evaluate the performance of the screening process. Actual results will be compared to the predicted outcomes with a focus on metrics such as screening completion rates and staff compliance. Feedback from both staff and patients will be analyzed to determine which aspects function effectively and identify and counter challenges. The objective is to assess whether the tool effectively identified unmet social needs and integrated into the existing workflow, and the findings will inform any necessary modifications prior to broader implementation. In the ACT phase, our team reviews the pilot results and decides next steps. We will adopt the screening tool if it works well across all departments. We will standardize it or make changes and adjust the workflow before full rollout. We'll create a sustainability plan that includes ongoing education, data monitoring, and feedback. To support sustainability, we focus on 3 components: monitoring the data, providing the staff education, and gathering the feedback. In the next PDSA cycle, we will expand implementation and identify our goals, which will include expanding to additional sites, enhancing our education, and improving our data tracking. Each new cycle allows us to fine-tune the process. In conclusion, addressing health inequities is urgent, starting with identifying patients at risk. Implementing a standardized screening to be completed on at least 80% of our patients at intake will happen within 1 year. By using the Plan, Do, Study, Act cycle, we can begin with one location, ensuring implementation is successful as we expand. Change that starts small, is studied, and approved upon makes the difference in our patient outcomes. Thank you for watching.